natural history, then treatment options, and finally concentrate on the complications, prognosis, and clinical management for those with HIV infection. This morning we did cover the epidemiology. There are a few points that I will make about the epidemiology because they weren't stated up front. Internationally, we appear to have reached peak HSV, and HSV levels appear to be on the decline. So in North America, where we have excellent NHANES data, the rates have plateaued and have started going down, certainly amongst the non-Hispanic white groups. There's a shortage of data in Europe, but there is a study from Germany showing a similar decline in their population. So that anxiety that HSV2 rates, which has continued to climb and climb and climb, it has not come through. The natural history, I'm sure you're aware of this. We start with initial infection. When people get infected, we don't actually know the exact transmission rate. We know that in about 50% of people, there are some cycles of replication in the skin that abort through natural immune processes. They don't establish infection. People will then go either straight into latency, which we think 3/4 of people do without a clinical presentation, only to subsequently become apparent when they reactivate. And 1/4 of patients, of individuals, will get symptomatic first episode disease. We now suspect that there is no one really out there that doesn't reactivate when they're infected. We used to say about 2% won't get a clinical recurrence in a year, but when you look at shedding data, everybody reactivates, and the rate of reactivation is variable. So how does the virus work? Well, as I mentioned, it gets into the skin, it can be directly inoculated into mucosa. Usually, if there are breaks, it'll be easier. Cycles of replication in the skin. The infection gets going in the skin and then it's cleared by immune processes, but during that stage, the nerves get infected and then it sets up latency in the dorsal root ganglion. So an initial infection